Thank you so much, Jorn, and thank you for the invitation. It's really an honor to speak in this forum. My role is to talk about the integration of the non-invasive tests, and I promise I won't repeat the slides you've seen yesterday. We talked extensively about this. What I'd like to do is to distill the big concepts, the eagle's eye view, to understand how integration of NITs play a role into what Jeff just mentioned in the integration of models of care as we're starting on this road. I feel like we're building a plane as we're flying it. So I think it's important to have a critical understanding of what we have today and where we should innovate. So I want to set the stage with a question. Which one is more terrifying? This or this? So shark attacks attack and kill 10 humans per year worldwide, whereas burgers attack 116 million people in any given day, only in the US. So there's a NAFLD wave, we know about it. Are we prepared? So the outline of my talk is to give, again, a big picture perspective on case finding using NITs and NAFLD, to review the care pathways we heard about yesterday, and I'll spend some time on identifying the critical breaking points and the opportunities for innovation. We need to know where the cracks are in the foundation before we build this house. So I'll set the stage with what we need from an NIT outside of the hepatology space. It should be accessible and acceptable not only to the primary care providers or the people who ordered them, but also to patients. They need to be reproducible so we can scale models built in a center or a country to other countries and maybe continents. Importantly, they need to be cost-effective and they need to be accurate. They need to have efficient case-finding properties with minimal false positives. So the choice of NIT depends on the target and the goal. We're moving towards earlier stage of disease to higher as we move to the right of this figure. The focus of today is on this left side in primary care, so we're talking about outside of liver space. We need high sensitivity biomarkers in this space because the role is to identify and exclude severe disease so we can manage those patients in that setting. As we move towards GI and hepatology, we need tests with higher specificity. By the way, FIB4 was developed as a static test to identify F3 and F4. We're trying to push its limits and really stretch it to identify F2, but it's a little bit of a harder task for it to accomplish. The other point I want to make is the prevalence. You see the lower bars there. If 25 to 30% is the prevalence of NAFLD, what we're focusing on using FIB4 as one of the NITs in this pathway is really to find those 1 to 2% of the people in a large population, maybe 5% or less if we move towards stage 2. Again, a very hard task to accomplish by itself. We know NAFLD is managed in the primary care setting, but this figure gives a big view of exactly how many people do we see. This is a study we looked into, a insurance claim warehouse data from the United States, where just maybe focus on the two left bars there. We looked at people who were diagnosed with NAFLD and had commercial insurance versus those without a diagnosis of NAFLD. And we simply asked, what's the number of office visits by specialty or primary care? And you can see the light blue, gastroenterology is 3 to 4%. That's how many people we see. Endocrinology, a very small sliver of a purple right underneath that. So the large burden of people managed are the dark blue, which is primary care, and then a mishmash of others, which is the gray. What about the costs? How much do we spend? What's the annual total healthcare cost of NAFLD patients compared to controls? This is NAFLD in blue versus controls in red. Just focus maybe on the solid line for the commercial people. Notice that the largest amount of money spent on these people is around the time of diagnosis. So we billed for a code of NAFLD. We followed them a year later. There's a difference of $8,000 per patient in NAFLD compared to $2,500. So it's a large burden of healthcare costs around identifying NAFLD. What drives these? What are the utilization rates that drive these costs, imaging, and this is data pre-elastography, so this is ultrasound, CT scans, whatever other imaging of the liver that people use based on their preference, ultrasound-guided biopsy, and then the second one is hospitalizations. We've heard yesterday a lot of people present late, so a lot of those costs are driven by that. So the distilled version of these slides is that the current NITs are designed, and we're asking them to identify less than 5% of the general population. And there's a great need to create clinical care pathways that are accessible to primary care and cost-effective. So what's in the current toolbox? We know this table. I won't spend too much time, but the top three lines are the blood-based biomarker. FIB4 is the biggest contender. NFS is very close in terms of performance. The proprietary tests outlined below, ELF being the next contender. And then we have the elastography with FibroScan and MRE, and you can see their comparative performance. So how do we put these things from the toolbox into a streamline care? This is a simple schema, again, distilled version of what do we need to do and not what we currently do, from screening to risk stratifying to referral. And there are several steps, and you'll see the schema across the slides, but I want to spend some time into how many steps it takes to get there. So step one, it takes NAFLD awareness. We need primary care physicians and our partners to integrate their clinical data, blood-based biomarker, body composition measures, health history, and all the other things to recognize that a patient is indeed at risk for NAFLD. Then they need to make the decision to order liver enzymes. Unlike what we heard from UK experience from John Dillon yesterday, I can give you the American perspective. There is not a plethora of AST and ALT floating into space that we can do we can use to calculate FIB4. In the healthcare system I work at, the common biomarker that is panel, or not test set that is currently done for annual follow-up of these patients includes only one of those, only AST and not the ALT, so it's not feasible to have an automatic implementation of a FIB4 calculator. Not that this is representable for the United States, but it's a representation of what happens in the real world. Then they need to calculate a score, either automatically, as we heard through ILF, or the pathway that Manolis presented, or they need to put the FIB4 calculator, think about doing that, and then they need to either refer, make that decision, or if it's indeterminate, order a second NIT. And lastly, they need to make another decision to refer after all these steps. So what are the NITs currently recommended? It's very encouraging to see that the societies are making an effort to put this into guidelines. This is a paper from this year from the British Association. They recommend FIB4 or NFS of NIT1, and then elastography or ELF of NIT2. American Gastroenterology Association, a little bit of a nuance there. FIB4 is first, followed by FibroScan, so a bit more simplified. This is also just a few months old data. But we don't know what is the case-finding performance at the population level yet, and we do not know what the impact on healthcare utilization is. Important as we move forward. So back to that schema, replace NIT1 with either FIB4 or NFS, and then NIT2 with FibroScan or ELF. This is the big picture that we have today. We heard from Manolis yesterday, how do these work? So if we do FIB4 followed by ELF, I won't spend too much time on it, but you saw the outcomes. It decreases the unnecessary referral. It increases the case finding of advanced fibrosis or cirrhosis. But to me, the most concerning part of this study, which I really liked, was this, that despite you saw Manolis' heroic efforts to engage the primary care physicians. He met with them, he talked to them, they were okay to get into this effort and participate, and yet half of them did not refer high-risk patients, which is very, very telling. What happens if we do FIB4 followed by ELF versus FIB4 followed by VCTE? Several studies looked at modeling, so Markov modeling scenarios. They're pretty much the same in impact of diagnosis of advanced fibrosis, healthcare expenditure, hospital referrals, and also differences in referral rates between FibroScan versus ELF as second NIT, not much difference. So the bottom line is, I think we dug enough to see which one should be first or last. I think the data is pretty clear. So distilled version of this second part of the talk, espresso number 2, is sequential use of NITs is a significant improvement over the standard of care, which before was a haphazard use of blood tests, imaging, and biopsy at physician's discretion, bringing those costs in the first year after NAFLD diagnosis to a sky-high number. FIB4 followed by ELF or FIB4 followed by FibroScan, pretty equal. I would say use them based on the local availability. But so far, the data are based on small prospective cohorts like the 2 we heard yesterday or Markov modeling. So we need more. How do these perform in real world? And then the last and the most important piece of this second part of the talk is that the primary care is sine qua non. So without which not. We cannot function on any of these systems unless a physician makes the decision to click a button or think that they need to do something. So I have time. I am an overanalyzer, and I want to use this left time to really analyze those cracks. If we are to build a care pathway that is based on NIT1, which is FIB4, followed by elastography or ELF as NIT2, where are the critical and sticky points? Because as we continue to think and to innovate, and this is an innovations in NAFLD Care workshop, we need to think outside the box. It's critical to identify and strengthen the weak links. So where are they? I'll go back to the simple schema, again, bird's eye view, and going to step 1, NAFLD awareness. In my view, this is the biggest one, and we've talked about this yesterday, and I commended Helen for putting objective data where do we need to start? How do we start getting into the primary care field and outside of the liver world? And I think there's a lot of work to do between guidelines, as we talked, and education and all the other things that I won't iterate again. But the ordering of the liver enzymes, it's another critical point. As I said, it needs to be, depending on the decision to click a button, they're not uniformly ordered in routine practice, and we can assume they are, but they are not. And we have to realize this. We need to change this view in order to implement this pathway if that's what we need. And then to keep in mind that these enzymes are normal in half of the patients with NASH. So if we build a care pathway that is based on the rule that ALT is abnormal, then we will disservice half of this population and maybe not identify them. Step 3 is to calculate the score. So what are the cracks at this step? Let's take a critical look at FIB4 and NFS and their limitations. The big one is age. We talked a little bit yesterday. I like this graph because it shows NFS at the top, FIB4 at the bottom, the sensitivity and specificity across age strata. And if you follow FIB4, because we've focused on this so much at this talk, if you follow it here, sensitivity is in these squares. And remember, I talked at the beginning about the need of having a highly sensitive test in the population to identify. It is useless at age 35, less than a towing cost, 35 to 40. And then it starts to become a bit more sensitive in this, as the age increases. That NAFLD wave I showed you at the beginning affects this population the most. The incidence increase in NAFLD is in the younger patients. So we are, again, disservicing them potentially if we are not finding them with FIB4. As the age increases, sensitivity is better, but specificity decreases significantly. What does this mean? We're going to identify a lot of people who have a high FIB4, put them through a pathway of NIT number 2, elastography, and all the other things with a lot of false positives, potentially. Another way to look at this data is how does FIB4 range on age strata? Again, the darker gray boxes are those with a high FIB4 above the cutoff we use of 2.67. And if you look again, this is basically pre-test probability, right? So if we look at younger people, follow the darker boxes, very little chance of having identify a high FIB4 in this, whereas the chance of going here is much higher. So a lot of these people are going to have a high FIB4 just based on their age. And this is only in people with abnormal liver enzymes, just by the way. So what about step 4? Cracks or opportunities to change at the referral level. We talked about the 50% drop-off in a highly intensive pathway that was created with a lot of effort, and then ordering a second NIT. So what happens if you have a second NIT? What happens in the real world if you have FIB4 and an elastography or ELF? How do they perform together? And I really love this study. This is a paper that's I think still online from the Barcelona group led by Isabel Gropera. This is the first study we can critically look at with real-world data from a large cohort of over 5,000 patients who had concomitant measurement of FIB4, NFS, and FibroScan from 5 independent populations, mainly from Europe, but also Hong Kong. And in this population, the prevalence of significant fibrosis is what we expect, 5%, and that of advanced fibrosis is about 1.2%. Focus on the FIB4. Again, we're going to just deconstruct this concept again here. So you have FIB4 here based on the 2 cutoffs we mentioned. This is good and this is bad up here. And then you have LSM less than 8, which is good, and more than 12, which is bad. So focus on those corners. Let's take those with a low FIB4, so those who would otherwise not be at risk for high LSM. Most of them are in that low box where we want them to be, which is good and it's reassuring. The NPV was 95%. I'd like to say that we do focus a lot on NPV, but when you have a disease prevalence of 5% or less, a lot of tests are going to have a high negative predictive value just by definition. So we shouldn't put all our money into NPV. The question is, who are we missing? So who are those people with low FIB4 who actually had fibrosis of LSM of over 12? And those were young people. 87% were missed due to a FIB4 of less than 1%. Let's focus on the intermediate FIB4 part. These are people who are going to go through either TEs or so FibroScan or ELF. So most of them were actually here. A lot of them did not have fibrosis, so they would go through unnecessary transient elastography potentially. In the top box of high FIB4, which are those people who we really care about and want to find, we want to find those people who are here, right? So high FIB4 with high LSM. That's how you get the positive predictive value. 16% in this study. So again, a lot of people who would be identified as false positive. And the question is, who are we missing? High FIB4 but low LSM? Answer is age. Over 65, 84% false positives due to a FIB4 of over 1.3. So this is large general population. Again, it's not stratified by high risk factor, but I think it's a very telling story in terms of how do they behave in the real world. The performance of NIT is just taken by themselves. This is for clinically significant fibrosis. This is for advanced fibrosis. FIB4 versus NFS versus waist circumference outperformed all of them here, especially in the 8 kPa cutoff, and a bit less here for the 12. So again, should we implement waist circumference instead of BMI or all the other FIB4s as we move forward in primary care? Maybe. It makes you think. So in this study, FIB4 and NFS had low accuracy in the general population. Again, the sensitivity is suboptimal. NFS was a bit better than this. Specificity is reasonable, I would say. Almost a third false positives because of age. 43% of those with fibrosis had normal FIB4, so false negatives. Who are those people? Diabetics, those with alcohol use, and young people. Again, risk factors, people that we do not want to miss in the clinical practice. So back to our diagram, we got to step 5. What are the cracks in step 5 where we refer? Is there enough time? We go back to yesterday's talk, and this is I liked this paper, it was really shocking to me. This measured the time requirements for discussion of preventative care recommended by the 110 guidelines that we heard about yesterday. In the United States, there's 4.4 hours a day spent on that. That's their 50% of their work time. In Europe is a bit better, 20% of their work time. I don't know if this is 2003 data. I would assume it's actually even worse now. So a quote from one of the papers is that there are not enough primary care physicians as the number of guidelines and tests increase, population ages, chronic disease rates increase, the healthcare delivery will be further strained. We need to keep this in mind as we move forward, because otherwise patients are going to diagnose us. So the final espresso, final takeaway points. Sequential use of NITs are a significant improvement over the previous standard of care. I commend all the societies and all the people who put so much effort into creating these models of care. The GI and hepatology governing societies have made official recommendations for clinical care pathways in NAFLD. This is hot off the press, new, we're moving, it's a good thing. But these need to be expanded to primary care and other specialties as we are using this momentum. This is the time to involve them. To paraphrase Ruth Bader Ginsburg, I think primary care and patients belong to all the tables where decisions in NAFLD screening are made, otherwise they're missed opportunities. And NITs need to be applied in the clinical context of risk factors because they have a very low sensitivity in the population at large. And as we continue to innovate, we need, I think, this is probably the thing, the key thing as we move forward, we need to try to find ways to decentralize the role of primary care. We need to incorporate automated processes that use the clinical data and bypass this stepwise approach because there are opportunities of failure at every single stage. I think there's hope ahead. I thank Jeff for trying to create this pathway for us. I think we can work together and continue to innovate, and I thank you for your attention.